Okay, this is Jaime Pittenger. Dr. Pittenger has been with us before on several occasions. She has her medical degree from the University of Tennessee at Memphis. I learned something new today. The University of Tennessee at Knoxville does not have a medical school. It's at Memphis. She's from Tennessee, and my husband is too, so I won't say anything derogatory. Anyway, that's my boss. If y'all have met Dr. Donna Grigsby, she's my boss. And it's like she's from Tennessee too. She's from Knoxville. But Dr. Pittenger is assistant professor of pediatrics, so she's on the faculty and staff, and she's a pediatric hospitalist for the Children's Hospital. And then she said that she's taken on the new forensics with the Children's Hospital. So it's like, and then she's got a family. It's just like, and then she agreed to do this, and that's why I love her. So please give your attention to Dr. Pittenger.
All right, so this is going to be interactive. At some point, we're going to use your cell phone, so just to add a little technology into it. So I'll show you that in just a little bit. But that being said, this is the only question I'm going to ask you where you have to kind of raise your hand, okay? How many people have heard of the Adverse Childhood Experiences Study? Okay, that kind of helps me. That's what we're talking about today, kind of what that translates into for pediatric and for public health in general, okay? I'm a pretty informal speaker, so if you have questions or you want to ask about something or talk about something, throw your hand up or throw it out and we'll kind of go from there, okay? But let's just go ahead and dive in. So our goal is to talk about what ACEs are. So in PEDS, we can't do anything without a really cool acronym. So Adverse Childhood Events, ACEs, fun. And identify how this impacts children and public health in general. Determine how resilience factors can change outcomes and how healthcare professionals can help. And just kind of broaden your knowledge. I am in no way able to cover everything about ACEs and traumatic stress in an hour. I will do my best and we'll cover a lot. Sometimes I talk too fast. So if I do talk too fast, tell me to slow down, okay? I want to send out a special thanks to Dr. Ruth Shepard and Dr. Erin Fraser. Dr. Shepard works in the cabinet, and so, you know, she's done talks on adverse childhood events and kind of toxic stress. So you sort of pulled some stuff from her talks and from Dr. Fraser as well. She is a pediatrician at U of L as well. All right, when you think of adverse childhood experiences, I want you to give me one word, and only one word, that kind of, when you hear that phrase, what does that make you think of? So what you do is you pull up your text, okay, and you type in the number portion, you type 37607 in the number portion. In the text portion, you type Jamie 2016, and then it'll send you back something that says you're logged in on a poll. And then you type in one word. Now, I will tell you, someone who was listening to this talk before typed in a cuss word, it does come up. Whatever you type in, it comes up, okay? And so hopefully it's going to make a word cloud as you type it in. I promise to log in as a one-time thing. So in the number part, where you type in the phone number, you type 37607. In the text part, where you would put typical words for a text, you type in Jamie 2016. And then it's going to send back that says you're logged in to the poll. Once it does that, type in one word, any word that comes to your mind when you think about adverse childhood events or experiences. And we'll go from there.
Tell me that I'm logged in. It's not it shouldn't matter. There it is.
You may have any questions so far?
Signal. Okay, so
This should be working.
just speaking from personal experience. One word. You like my one word? She's affair.
Okay. Well, technical difficulties being what they were, we'll just keep going on. The goal is to have like a word cloud. It works fine and has things in well.
Description.
So, before we begin, Dr. Robert Block, who is a former president of the American Academy of Pediatrics, said, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And so, rather than before we go through our talk, I'm going to give you the Cliff Notes version right now through a video. Okay? We'll see if it worked before I did it. I tried it just a minute ago. And then we'll go from there. So if you remember nothing else, this first 5 minutes is pretty good. That's what it's all about.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
Okay, so there's my talk really in a nutshell. See, they did a really good job, okay? So basically, so what happened was Dr. Vincent Folletti was in Kaiser Permanente, which is a huge healthcare group in California, right? The managed care group, okay? And so what he found is he did preventative health. Really, he did obesity clinic. And what he found was that he could get these people to lose a lot of weight just and kind of have more successful outcomes once they address things like what happened in their childhood. He kept seeing this kind of thing go over and over again. And so he wondered if that was kind of a commonplace or whether adverse events happened to everyone or this particular patient that kind of sparked his interest, if she was kind of unique. And so he got together with some epidemiologists and they decided just to send out random questionnaires to people that could link back to their medical records, right? And just ask the person a question that maybe they wouldn't necessarily ask one-on-one all the time during office visits, like, did you experience sexual abuse? Did you experience physical abuse? Now, and they would define all these things. So sexual abuse wasn't someone flashy. Sexual abuse actually had to do with contact and other things. Or physical abuse wasn't spanking, it was actual beating, or things like that. So there were kind of descriptors that they went through all of these. And they tried to pick things that were actually, they picked 10 things that they decided they could actually do something about. So abuse was one, you know, 3 of them. They went through all 3 different kinds, you know, physical, sexual, emotional. Then they went through neglect, you know, emotional and physical neglect. And then they went through 5 like household dysfunction things, just to see what kind of information they could get back. And what they found was that only a third of people had no ACEs, but otherwise 2/3 of people had 1 or more. And so they went in and then connected those back to kind of what medical illnesses they had and other things, what kind of health problems they had. Okay, just to kind of see, because as an epidemiologist, you want to kind of see, could there be a causal relationship? And I will tell you a quote from Dr. Anda. So when he was evaluating kind of the numbers from the study, and epidemiologists love numbers, he goes, this is the kind of stuff you see maybe once in a career, if you're lucky, just because the cause and effect. So what they found was, and I will tell you, like for sexual abuse, saying that 21% said yes, that actually has been validated kind of across different studies not related to the ACEs study. So if you kind of poll all comers, those people who admit later on to being sexually abused are about 1 in 4. That actually is pretty kind of standard. And so what they found was, though, that as you went up, it was kind of more dose related. So the more trauma you experienced, the more comorbid conditions that you had. Like for example, we're going to skip that. So how common are ACEs? Again, you know, about a third had 0, but then 2/3 had 1 or more. And so it made them think, well, if that's the case, is there something that we can do? What does this all mean? How do we relate this to healthcare? What they found was that ACEs, the majority of people who had, you know, more than an ACE, 1 or more ACEs, had things like obesity, diabetes, and it was dose dependent, right? The more they had, the higher likelihood, and we'll kind of go through what all this means in just a minute. COPD, broken bones, cancer, stroke, also high-risk behavior, STDs, drug use, alcoholism, mental illness, depression, and also lower academic achievement, more time off from work, more illness overall. So what does that mean in a different way? So if you look at ACEs, for someone all-comer who has no ACE, so no adverse childhood event, 1 in 16 smokes. Now look at that with those who have 4 or more, 1 in 6, right? So it doesn't necessarily mean all-comers with adversity or adverse childhood experiences have these things, but it does increase in probability. The remarkable thing are things like suicide. So all-comers with no ACEs, 1 in 96 attempt suicide at some point in their life. With 4 or more ACEs, it jumps up to 1 in 5, right? So that tells us that there's some correlation. We just didn't quite know what it was. So they started doing some studies as to what all this means. Because how can adversity or adverse childhood events actually be related to things like cancer. How do you make that leap, right? So just to show you, so if you look at this slide, you look at kind of what this means, if you have 1 to 3, kind of what that means for alcohol use and IV drug use and things like that. And we look at all 10 ACEs. So in the state of Kentucky compared to national averages, we are higher in every category for having more greater than 1 ACE, greater than 2, and actually greater than 3. If you look at that, we're one of the highest in the nation for having greater than 3 for all comers for children under the age of 18. Also looking at the poverty level, and I will say the United States in general has one of the worst childhood poverty levels for developed nations in the world. We are 4th behind Chile, Mexico, and Turkey. And the United States comes in 4th for kind of giving resources to children and things like that. So when you look at kind of your ACEs stuff, having discord leading to divorce or separation, again, higher than the national average. Having lived with someone who had alcohol or drug problems, again, higher than the national average. Witnessing violence, living with someone who was mentally ill or suicidal. And so ACEs scores, our kids are kind of behind the 8 ball to begin with, right? So what can we do? And that's kind of how I want to hedge this talk, is what can we do in the community to kind of help these things? The way it works is this. So you have these adverse childhood experiences. This leads to disrupted brain development, okay? When that happens, then you have social, emotional, and cognitive impairment. And what that means is, so for neurodevelopment, the basis of all brain development is based on relationships, right? So at the beginning of a childhood, a child when they're born, them developing kind of connections and all of that is kind of their relationships they have with caregivers and other things. That's the basis of kind of the next level, where they have the building blocks for their social function. Okay, so when they don't have that, their ability to kind of go to that next level and have those things like executive functioning, and executive functioning means like being able to complete tasks, being able to solve problems and things like that is lessened. Okay, when that happens, they have coping mechanisms, and so usually these can be considered, some of them are maladaptive. So you have the adoption of health risk behaviors, be it overeating, high-risk sexual behavior, drugs, alcoholism, etc. When that happens, you have social problems, disease, disability, etc. And then if you have enough of them, you can lead to early death, right? Well, so think about this. So most of these people have kids. So when they have kids, look at your top 3. This adds to the ACEs, so it's a perpetuating cycle, right? Which we knew all of that when it comes to alcoholism and things like that. But we didn't necessarily know how this related to things like COPD or high blood pressure or anything like that. So, does everybody know what this is? So these are synapses, right? So these are neurons, right, of a baby's brain. So when they're born, we don't have that many. I mean, we have a lot. They haven't made a lot of connections, right? And so the basic model is kind of a serve and return method. So what they do is a baby's brain is connecting synapses. So they're connecting neurons at about 700 per second. So it's constantly in action. But what happens is, at about 2 years of age, they have the most connections they'll ever have, right? So under 2 years of age, well actually under 4, that's the most plastic, if you will, a baby's brain's ever going to be. It's the most malleable and adaptable and trainable, right? And what happens is the serve and return method, when they have these experiences and the synapses are formed, then they have other experiences that back that up. So some of the synapses get bigger because they have those experiences that reinforce the pathways, and other ones go away. So then by the time we're an adult, you can see fewer, but some of them are bigger. Does that make sense? So, and I promise this is like neurodevelopmentally exciting as I'm going to get. So this is the baby's brain, okay? This is the prefrontal cortex up here. This is where all the money is for adult functioning, for like executive functioning, completing tasks, problem solving, being able to sit in a classroom, being able to kind of do the things that are necessary to learn, okay? That doesn't get developed until after kind of your fight or flight response system is kind of more developed. And that is this thing right here in the middle, okay? So the amygdala is kind of the gas, right? It's your fight or flight. It's the thing in your body that says, there's going to be a problem, let's get ready to go, okay? The hippocampus is kind of like the brake, it says, all right, everything's good, let's calm down, and they kind of cancel each other out after a little bit, right? But someone who has a whole lot of trauma, the amygdala never kind of gets put off, right? So they actually have a term for it. It's called amygdala hijack. And so it happens, it's always on. They actually have looked at brains in kiddos they took the brains and did PET scans of kids in Romanian orphanages who were kind of stuck in a bed and left there, so they didn't have really any social interaction, and compared it to your average, take that for what it's worth, American kid, right? And kind of looked at where their brain lit up at the age of 4. Okay? What they found was that the kids that were in the orphanage, this part of their brain lit up, right? But this part of the brain, which is needed for, adult functioning, didn't light up nearly as much. Okay, so there wasn't nearly as much activity. Okay, so the theory of thought is there are 3 levels of stress. There's the positive stress that's kind of like, oh crap, I got to study for a test. I want to pass the test. I got to study a whole lot. I study a whole lot. Oh, the test is done. That's great, right? And that's like normal stress. That's good stress. Okay. Then there's the tolerable stress. That's like your serious kind of temporary stress responses that you have, like the loss of a loved one. As long as you have, as long as children have nurturing adult relationships, right, that can kind of help them through this. The third level is this toxic stress. So these adverse childhood events kind of go into this toxic level of stress. It's a prolonged activation of that kind of whole stress response system. Okay? Now let me give you an example. So positive stress is, I'm in a forest and I see a bear. And for completeness sake, I am totally stealing this story from Nadine Burke, who's one of the founders of studying she's one of the founding pediatricians who really talks about ACEs. So if you see it on a TED Talk, I totally stole it. Okay, so if you're in the forest, okay, and you see a bear, your heart rate starts to go up. You start breathing faster. You get ready to run because who wants to say hello to a bear when you're in the forest, right? And then you're ready to get away from the bear, and everything goes back to normal. For kiddos who live in that household full of dysfunction, the bear is home with them. They're never away from the bear. They can never get out of that sense of increased heart rate, breathing faster. So things like decreased blood flow to the gut makes sense, right? Because when you're trying to run, you don't really worry about digesting food you're not going to eat, right? So it's not surprising that a lot of these kids have constipation or other issues, because that kind of goes right along with it. It's not necessarily, their baseline heart rates are a little bit higher. Their blood pressure is a little bit higher. These are normal physiologic response. The thing about it is they can't ever get away from it because it's right there where they live, right? And when that happens, okay, I was like, I couldn't remember what slide was next. I was hoping I said that stuff right. Okay, when that happens, you have cortisol release, right? So what happens is the brain says, okay, I'm stressed, I've got to fix this. So they release hormones, these stress hormones, cortisol is one of them. When that happens, that affects things like, yes, your heart rate, that affects your blood pressure, that affects, your digestion and other things. It also affects your ability to fight infections. It lowers your immune response, okay? And so it lowers your ability to produce antibodies and things like that, so you're more prone to infections. But it also does this really cool thing, and it changes your gene expression. It's called epigenetics. It's a buzzword for kind of trauma-related care right now. And so basically what it says is your biography then becomes your biology, okay? So if you experience something very stressful, your body becomes much older than you are in years, because it leads to changes. And what that is, so if you look down here, that's a DNA helix. And so this is kind of a normal gene, right? And so instead of changing the makeup of the gene is the same. It doesn't alter that. What it does is it adds something. It's called methyl groups. That doesn't really matter. Basically, it's like a volume control knob, right? So it amps up the volume of things. So things like your cancer genes that the expression may be turned off, when you add these methyl groups, so when you add the methyl groups to that, you'll turn them on and it ramps up the volume. So it's not surprising that things like cancer and other things are more prominent. And the thing about it is, once that happens, those just don't fall off. They kind of reproduce and they can be passed on. So then they're passed on to your children, right? It's not necessarily permanent, but still. They did a study in they looked at, in the state of Kentucky, we have a really high opioid use problem. I don't know if you know that, but we do, right? And so we have a lot of these babies born substance abuse. And what they found was that mothers with chronic opioid use, right, their children, their gene expression, so their ability and response to pain and stimulus, they have added methyl groups. Yeah. And these methyl groups make them have more withdrawal after they're born. So it's because of chronic opioid use in the mother changes her gene expression in the kids, therefore they have worse withdrawal, right? So if we can decrease the amount of opioid use, an easy task for public health there, we can actually change outcomes and decrease hospitalizations. Does all that make sense? Clear as mud? Okay. And so you think about this, and if that's part of it, if we can change the way we approach these problems, we can actually change the health of our entire country one generation at a time. Yeah?
Do you know about the HANDS program?
Mm-hmm. I sure do. And actually, so we're going to talk about that in a little bit, but briefly, not a whole lot. But I will tell you that the HANDS program, they have seen like a third reduction in premature birth, a third reduction in fetal demise, a third reduction in substance abuse, and a third reduction in, and I'm off in a few percentages there, in depression and other things like that. Just through simply having someone in the home, and it improves outcomes in the children as well. Because there's this critical period of brain development, right? So you'll hear a lot of people talking about the first 1,000 days. So by the time you're 4, your brain is about done. Now it can be tweaked a little bit, but that's kind of it. So that's why we focus on these little kids and trying to put our healthcare. When you hear a lot of pediatricians talking about wanting to put healthcare stuff into the neonatal period, the toddler period, that's why. Okay.
Kids in prenatal through the 3rd birthday.
Mm-hmm. And then there's also first steps and other things. We'll get there. So I'm not saying that just because you had adverse childhood events, you're just kind of messed up on the genetics for the rest of your life. I don't mean that, but what they found is just like there are risk factors for having poor health outcomes, there are also protective factors that lead to resiliency. That's another buzzword if you want to look up like trauma-informed care and things like that, resiliency. And so things like social support from family, from schools and communities. The coolest expression I ever heard is every child is one caring adult away from being a success. All it takes is one person caring about how they're doing and what they're doing, and it can change the trajectory of their life. Okay? That being said, even when you have a lot of negative outcomes, if you have those foundations, you can kind of tip the scale in the other way. And so, I need to quit moving. Dr. Ginsburg talked about building resilience in children and teens. And so what he said was, we need to quit worrying necessarily about the end result, but about how much they tried. And what he means by that is, yes, it's important, to make a good grade on a test, but we also need to worry about kind of the effort that it took to be there, and instilling confidence in their ability to try, and also to kind of form these connections. He said, dare to care. Actually try and have meaningful conversations about what's going on, and show them kind of, lead by example, show them kind of right and wrong, among other things, and then show them other ways to cope with things. Because I'll tell you, these habits that we call maladaptive, such as smoking, drinking, overeating, and things like that, it's just a coping mechanism. So rather than necessarily thinking about it as something bad, we should think of it as, what happened to you to make this the way that you cope? And if you think about it like that, you can kind of help lead someone to find a different coping mechanism. And then, control. Just know, the big thing he talked about, that discipline is supposed to be for teaching, not necessarily for controlling what they do. And setting expectations, because that's the other thing. Kids really want to kind of have somebody in their corner who wants them to do well and expects that of them. But the trauma-informed approach, so trauma-informed care is a big thing that's coming out, and it's a big public health initiative as well. And so basically what it says is, instead of asking what's wrong with you, ask what happened to you. It changes kind of the whole tenor of the discussion, if you will. It doesn't necessarily, it's not supposed to give them an out, but it's supposed to help open a discussion that may otherwise be kind of uncomfortable. And so basically in the trauma-informed approach, their whole thought process is a three-pronged thing, right? So you have trauma-aware, so it's education like this, okay? Trauma-informed, and so trauma-aware is more like everybody needs to know that this is what it is, that these things happen, and this is what it can lead to, because knowledge is power, and if you at least know, you can sometimes help people make better decisions. Trauma-informed care, you take your at-risk population, and you make sure that not only they're aware of what some of the risk factors are, but then we also give them resources, things like the HANDS program and other things like that. And then the tertiary thing is, people who are already having problems, you get them involved in multi-generational, or usually they say bi-generational, therapy of some sort. So you deal with not only the children, but also the adults as well, okay? But so for healthcare professionals, the big things are, so just like when you ask social history or a health history, you need to include things like, have you had any behavior changes lately? So, school health nurses in the schools are at a really unique opportunity because kids come in. You can ask things as simple as, has anything scary happened to you in the last month? Because just being able to open up that dialogue can help open up resources. You'll be amazed at what kids will tell you just by asking. Things like, have you had trouble sleeping lately? How's your school performance? Has there been any change in school performance recently? Has anyone come or gone from the household recently? We talk more about violence and its effects. So just like we talk with mothers or caregivers, I kind of go to moms because moms come to a lot of well-child appointments. We talk with them about what healthy eating habits are, what the basic food groups are and kind of how that's important and all of that. We talk about things like limiting your TV exposure and things like that. We should do the same thing with trauma and talk about the fact that this can lead to long-term effects for adults, and we have the chance right now to make a difference because sometimes just knowing and giving them the resources that are available can make all the difference in the whole world. So the big things are, I took this from kind of helping foster families cope with trauma and children that they foster, but the big thing, how people can respond, which I think is really important. Don't take behaviors personally. Okay, sometimes that's the only way they can cope. Because the thing about it is, a lot of times, when these kids act out, when these kids who've had multiple adverse childhood events, you'll see them in schools, they have things like inattentiveness, inability to sit still, aggressive behavior, easy distractibility. Does this sound familiar at all? Right? So what they found was there's a significant link between people who present with ADHD and kind of adverse childhood events. And kind of it's the same type symptomatology that they present with. And so the big things are, the other takeaway point is, if they haven't had those building blocks, if kids haven't had that relationship and kind of the social building blocks that go to that next level of executive functioning, they can't perform in school like they're supposed to. They can't learn because they're too busy trying to do your basic fight or flight kind of thing. Actually, when they look at the size of their brains are actually smaller. Their hippocampus, the brain is actually smaller because the amygdala, or the kind of gas pedal, is on so much that it changes the size of their brain, and kind of it also changes their ability to function. So we can't expect these kids to sit still and learn when we haven't given them the building blocks to do these things. The big things are, avoid yelling and aggression. I need to work on that with my own kids. I yell entirely too, mainly because they act deaf. But that I haven't said it on the 4-year-old twins, but that's beside the point. Helping your child understand your facial expressions. So they don't really have a good grasp of what social norms are. So they don't necessarily know how to tie emotions. So sometimes their aggressive behavior isn't necessarily because they're mad, it's because they're afraid or because they're sad, but they don't know how to label those emotions nor how to deal with them. And so being able to kind of label emotions and kind of say, so how do you feel? Do you feel sad? Or I feel sad about this, kind of giving them an example and kind of mental model is helpful as well. What can be done? So the big things are there's a whole resiliency movement that Pediatrics is kind of pushing forward. But there are several things. So home visiting is prevalent, so the HANDS program is one. First Steps is another. Head Start is another. These are resources that we have in Kentucky. There's also been, for adult care, there's also been a big push in public health about mental health programs and availability and things like that. I'm not saying we're perfect, but we're better than we used to be, and we're still working on that. And then also from Kentucky in and of itself, we're still working on neonatal abstinence syndrome, and kind of we're working on talking to families about opiate exposure and what that means and all of those kind of things as well. So kind of an education plan. The other thing is that I just completely forgot what I was going to say. So just kind of, we're working with moms to kind of, and families to know what that means when a child is born, go ahead and do kind of what that means for their future and things like that, so that families can be aware of what kind of some of the problems could be as they go home. There's also, in Louisville, they started something called a BOUNCE program, which is supposed to kind of help families kind of be more resilient and help the kids in school and things like that. It's kind of an integrative approach. You can look it up, BOUNCE. So take-home messages. Toxic stress can alter the course of a person's life for them and generations to follow. The lifelong toll of unaddressed adverse childhood experiences is perhaps the major cause of death and disability in adults. I will say that, on this point, by 2030, over 90% of disability in developed, death and disability in developed countries is going to be from non-communicable diseases, such as COPD or hyperlipidemia or coronary artery disease. Over 90%. If you look at those, the majority of non-communicable diseases can be directly related to the proportional exposure to adverse childhood outcomes. So this is not just me trying to be all, let's change the world. I will say if we can change how we approach childhood and kind of the interventions that we give, we can affect our future on our healthcare dollars. If you want to break it down to dollars and cents, an ounce of prevention now saves about 115 on the dollar in the future for healthcare related costs as they get older, right? It just makes sense. But the problem is, it's kind of how do you prove negative, right? It's kind of like vaccines. We know they work, but how do you prove negative? Well, you stop giving vaccines and then the process comes back. But that's beside the point, okay? And then the other thing is, every child is one caring adult away from being a success story. So we have a lot to learn about how things work and why we are the way we are. But I do know that we can change kind of the trajectory of our public health and our healthcare dollars by being more trauma-informed and trauma-aware. So, questions? I was done on time. I had my timer ready. I'm actually done a little early. Do you have any questions? Yes.
I know you touched in there into a little bit on the HANDS program. I don't know how many of you work for the health department, but I did actually do some HANDS training. And when I'm not, because I was going to be filling in, I don't do it so much anymore, but in my capacity as getting immunizations and week and things, I promote the program to our moms coming in with positive pregnancy tests, things like that. But they are teaching this very same, the synapses, the connections, the brain development, and how important every interaction that child with the parents and grandparents and all, how that affects them throughout their life. So I know I sound like this, but if you get to know your HANDS people and what they really do, and really promote it, because this is what they're doing.
I will just say, these studies that we're talking about were done in like 1995. So it's just taken 20 years for us to really start talking about it, which is exciting. As pediatricians, we still don't do the trauma screening like we should at every well-taught tech. Now, to be fair, if you did everything that Bright Futures, the American Academy of Pediatrics, recommends for every well-taught tech, they'd all be like 4 hours. But that being said, we can at least ask the question. And so we've got to start doing a better job ourselves. So.